I'm Dr. Amajoyi. I'm a colorectal surgeon. Welcome to the Colorectal Symposium. I'm from Kansas City. Yes, go Chiefs. Is it
Yeah.
Texas. Hello? Yes. Perfect. So go Chiefs, right? Woo. All right. I'll be moderating the session with my co-moderator, Dr. Harry Anderson. And this session is really designed to review some of the difficult and challenging cases the on-call general surgeon or colorectal surgeon will encounter. The presentations will focus on the topics such as stoma complications, obstructed colorectal cancer, complicated sigmoid diverticulitis, lower GI bleed, and rectal prolapse. So the participants in this session will have a better understanding of the issues related to colorectal surgery. And I do have the speakers, distinguished speakers on my side here. The first of which will be Dr. Kondylis, who will give us a talk on obstructed colorectal cancer, nightmares from the emergency room. And Dr. Kondylis is a very good friend of mine. He comes from the GI program. He's an educator. He was my program director for colorectal surgery. And after that, Stoma and Stoma Complications will be presented by Dr. John Kidwell, who is an assistant professor of surgery at Texas Tech Sciences Center. He's a colorectal surgeon. And then followed by Dr. Erna Tanchu, who is out of Bentonville, Arkansas. She's a colorectal surgeon in private practice. She'll be talking about lower GI bleed. And Dr. Nsikai Umar is a private practice colorectal surgeon out of Woodlands Colorectal Associates here in Houston. And he will be talking about rectal prolapse. Help, my rectum is falling out. And finally, the last but not the least, Dr. Izo Bohari from Amarillo, Texas. A lot of Texans here. He's going to be talking about the current management of complicated sigmoid diverticulitis. He's an associate professor and associate dean of faculty development in general surgery. And he's a colorectal surgeon interested in doing robotic surgeries and laparoscopic surgery. Now I'd like to present to you Dr. Philip Kondylis, who will be talking about obstructive colorectal cancer nightmares from the emergency room.
Good morning. Thank you for the opportunity to present. The slide is correct. I have no financial disclosures to make. The only disclosure I have is that I recently left the HCA system, actually to return to Erie, Pennsylvania, in the Allegheny network there. Obstructed colorectal cancer. To be honest, I don't think I've ever seen one of these patients in the office as the index presentation. They're always in the ER. They're always a consult, or they're a transfer from another facility. Patients with true obstructing colorectal cancer, they tend to be hospitalized. They tend to be sick. It's an insidious onset. But I find that the greatest challenge is that many patients are sent to me for obstructed colorectal cancer, many of which are not obstructive, some of which don't have colorectal cancer. Where I am, we're fortunate that we have a third-year resident who's free to triage all acute transfers and ER consults, and that simplifies things dramatically, so that by the time the patient is on our service, we know for a fact whether they have a malignant obstruction or not. Type of things we look for. If they were scoped and the scope went through the lesion, it's hard to see it as a true obstruction. Not uncommonly, there'll be a relatively tight lesion, or the patient is impacted above the lesion. And not infrequently, people will come with pseudo-obstruction or volvulus that need an entirely different management. These patients, they do tend to be sick. There's a immediate need to rehydrate them, fix their electrolytes, medically stabilize them, figure out what their other comorbidities are. Not all obstructions are created equal. The location of the obstruction dramatically affects management. Some management is straightforward, and as we'll see here shortly, some is much more controversial. Proximal obstructions, they tend to be the most controversial in regards to potential stenting. Fortunately, most of these patients are resectable and usually reconstructable. So probably 9 out of 10 have relatively straightforward management. All the discussion and angst comes over the patient who would otherwise be resectable but is terribly frail. They have a horrible albumin, pre-albumin, they've lost 40 pounds in 3 months, their functional status has deteriorated. Classically, these patients would be resected and would have an end stoma. Now it's within the realm of discussion, are they potentially stentable so that they can be prehabilitated to be made a better operative candidate and hopefully avoid 2-stage surgery. Again, this could make for some complex discussions with the oncologists, who in general would much rather have the patient resected in a stoma, and from their standpoint, they can always be put back together when they finish their chemotherapy, which oftentimes places the oncologist and the patient at loggerheads. Patients who come with unresectable lesions, again, a relatively uncommon cohort. They have invasion of the cave of the liver, the duodenum, things that make it a much more complex, multi-visceral potential resection. These patients are very good candidates for stenting, in my opinion. If you can stent them, they can go on and receive the best available oncologic care, and then they can be determined whether there's any role for surgical intervention after they finish chemotherapy. And again, palliative management is another very commonly employed indication for stenting in these patients. They have widely metastatic disease, and you can stent them to palliate their obstruction. They can go on to have chemotherapy and assess the outcomes at the completion of therapy, or if they choose hospice-type management or palliative care, the stent will usually carry them through that interval. On the right side, there are some special challenges. These can be difficult patients to prep. The prep may have to be from below, it may have to be over several days. In some providers' hands, they'll stent with either fluoroscopy or endoscopy, but right-sided stenting usually requires both to be available. In terms of technical challenges, because the right-sided lumen is so much bigger, the stent luminal diameter is a fraction of the true luminal diameter. When you place the stent, it can be very challenging to get a 0-degree flat angle placement of the stent. The stent will sometimes lie obliquely. That doesn't necessarily compromise its function. What would compromise its function is if it impinges on the ileocecal valve. The other technical challenge is that you have to have enough room before the ileocecal valve to coil your wire. Otherwise, it's hard to know where the apical end of the stent is going to deploy. Left-sided lesions have a long and storied literature, all the way from 3-stage resection, all the way to the newest technique, transanal decompression tubes. The vast majority of patients are either a candidate for resection in a proximal stoma, a Hartmann procedure, or they can be stented. It's very unusual to need any of the older classic procedures. SEMs, self-expanding metallic stents, for colorectal purposes are almost always bare metal. There's too much migration with the coated stents. There are many manufacturers that come in different calibers. They taper to different conformations. They're essentially, from my standpoint, interchangeable. My facility is going to buy the cheapest stent they can get. They don't care who makes it. They want it to be a zero-par item, in that if you go to the endoscopy unit, no stent will be available. They have an arrangement where it's overnight delivery. We're fortunate in Orlando, the reps live there. So if you needed one same day, the reps would drive you out a box of stents and you pick the one you want. Otherwise, it's there by 10 a.m. with FedEx, which is becoming sort of a growing trend in the US to literally have a zero par for an item like this. But the stents have been available for 30 years. In Europe, they have a removable stent. It's literally designed with an eyelet, much like the vena cava filters, so that they're easy to remove if you don't need them. It's coming to the US, but not quite here yet. In my experience, they're not that hard to remove. So if it costs more, I don't expect my facility to purchase it. Stenting technique, as I alluded to before, there are many different ways of getting the stent in place. For left-sided resections in Europe, my understanding is that many of these procedures are done by interventional radiology, employing fluoroscopy only. Where I practiced before, very few folks used fluoroscopy. They were placed primarily endoscopically, direct vision. I was taught to have fluoroscopy and endoscopy, and I've not really migrated far from that. I like being able to have both modalities so that when I fire it, I'm very comfortable that I'm happy with where I'm positioning. Outcomes are fairly good. The criteria of technical success, you're able to place the stent, it doesn't perforate the colon, and it decompresses the lesion, is good 9 out of 10 times or more. Clinical success, where you technically deploy the stent and you get the clinical outcome that you want, is almost as good, 8 to 9 out of 10. In terms of palliation or bridge to surgery, again, about 9 out of 10. In terms of complications, large studies look at about a 1% mortality from stent placement, about a 4% perforation risk, and a 10% risk of migration. Migration is a mixed bag. Sometimes the stent migrates because they did great with their chemoradiotherapy and the lesion melted away. It can be a problem if the stent migrates above the lesion. That can distort the lumen. It can make it very hard to place a salvage stent. In terms of avoidable problems, someone who has a long-term stent in place, they need to be scoped from time to time so that you can essentially mow the lawn of the tumor ingrowth into the stent. They have to be managed in terms of diet to avoid impaction above the stent. And they have to be monitored for migration. If they have a sudden change in function, a simple abdominal film will often tell you whether the stent is still in position or not. The transanal decompression tube is rarely used in the US. It's much more commonly used abroad. It's essentially similar to the colonic decompression tube that we employ for pseudo-obstruction, except it has a relatively generous balloon at the apex so that you can position it above the lesion and it's much less likely to migrate out. In fact, I've been tempted to try and get them to use them for pseudo-obstruction patients in hopes of keeping the tube in perhaps a little bit longer. Is there anyone who has an experience with a TDT? And, all right. No, there's plenty of literature. It's just, for whatever reason, never caught on in the US. So rectal obstructions, this is essentially where stenting started in the colorectal. These are usually advanced lesions. Not uncommonly, there'll be invasion of adjacent structures. Mesorectal fascia can be compromised. Lymphadenopathy is not uncommon. These are usually people who are great candidates for chemoradiotherapy for their locally advanced rectal cancer. The problem is that they won't tolerate it given their obstructed status. If you operate these folks, they clearly have a greater risk of a non-R0 resection. So these are difficult situations. And as I tell the residents, if you can avoid primary resection, this is not going to be a good operation for the patient, and it's not going to be a great experience for the surgeon. because there's very little room in the pelvis, especially low in the pelvis, and when the tumor takes up all the space, I don't think it matters whether you have a robot, a laparoscopy, or an open case. They're technically demanding, and the outcomes are not as good. So decompression options, the classic, fast, easy, available everywhere, loved by oncologists is the loop stoma. It's easy if the patient's terribly frail. You can essentially do it under local if you had to. You can pull up a loop, you can make a blowhole, you can make a proper transverse stoma. The patient's decompressed, the oncologist is happy, the length of stay is relatively short. Sort of folks are happy, the patient may not be happy. And nowadays, many of my referrals for rectal stenting are from the patient family. The patient is told you need a colostomy. They get their phone out, they're on Google looking for alternatives to colostomy, and fairly quickly they come on stenting. Sadly, that's all they read. They don't read about the potential downside of a stent. So there's a substantial education component that's required. Most patients who go to stenting, TDT, avoid a stoma. It allows you to prep the patient. It allows you to clear the proximal colon, be certain there are no synchronous lesions. When you stent someone, the patient's happy, the family's happy. You have to be very careful that they understand that a perforation in that setting is a catastrophic problem. If they were to perforate, their outcomes are diminished. Survival drops, local recurrence increases. So there has to be a very clear understanding. So stenting challenges in the rectum. The lower third lesions are challenging and at times very challenging. One has to be very careful that if you have 2 centimeters between the bottom of the lesion and the anal rectal ring or the levator plate, it's relatively easy to stent them. When you have less than 2 centimeters, you're sort of dancing on the head of a pin a bit. And the package insert recommends not placing one closer than 2 centimeters to the anal rectal ring. So you have to be certain that as you place that when the stent has deployed, that it won't be impinging on the puborectalis, the levator plate, the anal rectal ring, whatever your preferred term is. If you do that, they'll have tenesmus, they'll have proctalgia, they can have incontinence. I caution all these patients that immediately after placing a low rectal stent, they're all going to feel like there's a grapefruit in the rectum. It's just a lot of pressure. There's no extra space in the lower third of the pelvis, so they feel the pressure immediately. And I encourage them to try and ignore that for 8 hours. Within 8 hours, that stent is as deployed as it's going to be. As it continues to deploy, it'll even foreshorten a little bit, and a lot of that initial pressure simply goes away. If they're still having symptoms, then you're in a position where you can remove the stent if need be, or you can try and tailor the stent. The literature talks about argon beaming off the lower component of the stent to buy a little extra space above the anal rectal ring. My personal preference is to go to the OR and transanally literally trim off the bottom of the stent. I try and take off no more than 1 centimeter. The more you take off, the greater the risk of it migrating above the lesion, which is difficult to explain to the family and a little embarrassing. So one has to be very judicious with how much they trim off.
1 minute. 1 minute.
Okay. All right. In that case, that concludes my presentation. I want to keep things on track, and when the opportunity presents, I'd be very happy to take any questions.
We do have 5 minutes of questions. Since we finished really early, there's a second stage. Anybody has a question? Come on.
My name is Hussein. I'm one of the surgery residents. Quick question. It's a great talk. So, what's your algorithm? Like, do you try to avoid surgery as much as you can, try to sit and then do surgery, or try to? Of course, it depends on the stability of the patient, or you try to do upfront cancer operation.
Whenever possible, I prefer to do the upfront cancer operation. When I'm boxed in, the patient's a terrible medical status, but I think they can be rehabilitated, then I'll stent them. If they're palliative cases, stenting is easy, especially if they want to go to hospice. So stenting is in my toolbox. It's for cases that are uncommon or higher risk, or the patient just absolutely refuses a stoma. So if their refusal pattern is, in my opinion, unwise, I may not stent them, but if there's a coherent pathway that sort of I can live with as the surgeon, then I'll stent them and allow them to go to best available oncologic care after that. Sir.
Dixon Santana from Lubbock, Texas. So as a vascular surgeon, as I hear about stent deployment technology and knowing where they fail and the pitfalls, I can't help to think about going through the deployment process of this on a tumor at any given location in the colon. So how do you determine the diameter that you need to use for your best possible size to relieve the obstruction? Do you use any extra imaging like CT colonoscopy to determine that diameter or internal luminal diameter? How far do you over dilate, if you over dilate? For example, in aortic surgery, we want to dilate about 10-15%, but not more than that, and that's mainly to make sure that the stent stays in place and doesn't migrate. So are similar concepts taken into consideration in this technology? And then in terms of cost, again, I'm extrapolating some of the data that we go through in vascular applications. Some cases, when you consider if you have two modalities of treatment, you got to factor in the difference in cost. Is it better to do a stent where, yes, it's going to be quick in and out, perhaps the patient's going to recover a lot faster, but then we fail on including the long-term cost of following that patient with that stent, as opposed to do an open surgery that, yes, the patient initially might take a little bit longer to recover, but in the long term may have a shorter, less expensive care. How do you go about that?
Well, in the colorectum, we tend not to dilate. There's some data that shows in the colon and rectum that dilating before stenting increases the perforation risk. In terms of diameter, the choices in the colorectum are relatively limited. 21, 23, 25 millimeter diameter is the biggest that's available. I always place a 25. I like to be able to scope through it without worrying about destroying the scope I'm using. So the 25 is my go-to. We always try and leave as much stent above and as much stent below as we can. The colorectal stents, they tend to be flared, so it's a little easier to keep them in position. In terms of long-term, almost no stents are meant to be long-term. If I'm putting a stent, it's so that the medical condition can be improved or that they can complete chemoradiotherapy, and then the stent comes out with the surgery. So long-term for a stent is often less than 6 months.
Thank you.
Thank you for that talk. Ken Pepe from Sioux Falls. My question is for the radiation oncologist. Are they seeing more side effects related to radiation with standing in place, or using less doses, or using different techniques than you have said?
I've not seen a significant difference in bad radiation outcomes. In the span of my career, I went from, as a resident, seeing a lot of radiation burns and suboptimal radiation outcomes to now where it's quite rare to even see terrible dermatitis. The technique of providing pelvic radiotherapy has improved dramatically, and our radiation oncologists don't hesitate to radiate with a stent in place.
So thank you very much for the questions. Now we're going to have our second presenter, Dr. John Kidwell from Lubbock, Texas. He's going to be talking about stoma and stoma complications, how to treat perfect stoma.
All right, can everyone hear me? Thank you, everyone. Can you hear me okay? All right. Thank you very much. My name is John Kidwell. I'm one of the colorectal surgeons for Texas Tech Physicians in Lubbock, Texas. Thank you all for coming. Thanks for having me, Dr. Santana. What I'm here to talk about today is stoma complications, how to create the perfect stoma. A lot of what I'm going to go over is how to try and prevent stoma complications, and this is especially appropriate in a segment about colorectal emergencies, because in emergencies that's usually where you're creating more stomas than you would otherwise. I have no disclosures. So why is this important? Well, there's about 1 million ostomates walking around the U.S. right now. We get about 150,000 new ostomates each year. So there are a lot of people walking around with stomas right now, and the morbidity range of actually creating a stoma is somewhere in between 20 to 80%. For elective cases, it's lower than for emergent cases. Emergent cases, you're looking around 50% complications associated with your stomas. Most common complications are going to be peristomal skin complications and peristomal hernias. Of course, there are other complications we'll get into: prolapse, retraction, mucocutaneous separation. But these things are very anxiety-ridden for the patients. It's also a sign from the patient you have increased cost, increased hospital utilization, and so it is, a big bang for your buck to try and instill certain things to help prevent these complications. So how can we decrease the incidence and severity of these complications? First is perioperative education. Then we get into stoma site marking, proper surgical technique, and post-operative care pathways. So we'll go into each one of these a little more. Preoperative education about the stoma by the wound ostomy care nurse and by the specialized provider, meaning the surgeon, actually has been shown to decrease length of stay in the hospital, decrease patient anxiety, decrease actual complications, and increase patient quality of life. These are small things that really make a difference, and they're easy to do in your pre-op visit. Meta-analysis of 68 studies identified six risk factors associated with stoma complications, and one of the main ones was someone not getting preoperative education and stoma site marking. The preoperative education that we give typically is with me and a wound ostomy care nurse before they undergo surgery. As far as the preoperative stoma site marking, there's a lot of good evidence showing that preoperative stoma site marking actually decreases wound complications. This oftentimes I feel like isn't done in the emergency setting, sometimes because you don't have wound ostomy care nurses available to you. That's okay, you can do it yourself. Some of the important things are evaluate them in multiple positions, the most common being laying down and sitting up. Some people even evaluate them while they're bending over. You want to avoid skin folds. You want to ask them where they use their belt line. Typically, I will put things more cephalad on the body than caudad. just because a lot of the patients we deal with are larger, and there are some benefits to being more cephalad, which we'll get into as well. So stomach marking decreases. It's been shown in systematic reviews to decrease complication rates, including prolapse, retraction, necrosis, hernias, and skin complications, and improve the quality of life. Principles of marking we've kind of gone into. You do want it to be within the rectus abdominis muscle. That helps give you a buttress against peristomal hernias. And it's ideal to have a 2 centimeter perimeter of skin around your stoma. So where do you put it? You know, it's nice to say, yeah, mark them, do it right, but how do you do it right? I typically find that I have fat fingers, maybe 3 fingers for some of you know, but if I usually go 2 centimeters cephalad and lateral to the umbilicus on either side, depending if it's colostomy or ileostomy, that usually lands in a pretty good spot away from a skin fold. So I can do that cephalad or caudate, 2 finger breaths above and lateral or below and lateral on either side. And you can do that while they're on table, you know, if you weren't able to do it when they were in the pre-op setting. Another technique in putting in stomach marking is drawing a triangle between their infraumbilical area, their pubis, and the ASIS. And then if you go in the middle of that equilateral triangle, then usually that lands you in the middle of the inferior portion of your rectus abdominis muscle. Again, I typically go above the umbilicus if I can, just because larger patients, you have less pulling on your stoma if it's cephalad, because you have less of an abdominal wall there. Post-operatively, after we've created a stoma for someone, we have, this is part of the perioperative education, we have people come to short-term follow-ups within 1 to 2 weeks of stoma creation, and they follow up with the woundostomy care nurse. There are studies, observational studies, and a randomized control trial that short-term follow-up here with the woundostomy care nurse actually decreases stoma complications as well. Improved quality of life, increased ability for patients to take care of themselves, and decreased anxiety with their stoma. So I think that's very important and has been added to our practice. Whenever you're creating a stoma, this is, you know, take this with a grain of salt. I know a lot of times the colorectal emergencies, we don't have the luxury of doing them minimally invasively, sometimes with obstructions, very dilated bowel. But if you can create a stoma minimally invasively, that does have advantages to it. Those advantages are extrapolated from open versus laparoscopic surgery for other things as well. So you have reduced pain, shorter hospital stay, earlier return to work. Also, we do have a retrospective study showing that the minimally invasive created stomas are easier to reverse and wind up with a shorter hospital stay and lower complication rate. So which one do you do, loop ileostomy or loop colostomy? Which one's better for fecal diversion? They're both good for fecal diversion. Usually which one you do dictates on where your lesion is or where your disease process is. So if you have an obstructing distal colon cancer, typically you want to do a loop colostomy, because if that person has a competent ileocecal valve and you do a diverting loop ileostomy, they can still have a closed loop bowel obstruction because of their competent ileocecal valve and their distal colon mass. Getting into the details of loop ileostomy versus loop colostomy just on the basis of how good they are at fecal diversion and what their complications are. We do have 5 randomized control trials and meta-analyses that show that loop ileostomy creation has a lower prolapse rate, lower retraction rate, lower peristomal hernia rate, but it does have a higher rate of dehydration when compared to loop colostomies. Whenever you're attempting to reverse these, loop ileostomy closure you have a higher rate of post-op ileus, which is somewhat annoying, I could say, on the ward sometimes. You just want to, reverse them and then tell them they can go the next day. But sometimes you do see that post-op ileus. Also has a lower rate of surgical site infection, less bacteria, obviously, in the small bowel, and a lower rate of incisional hernia. Again, pretty obvious. You usually have to make less of a defect to bring up the small bowel than the large bowel. Protrusion above the skin, you do want it. You don't want to create a flush end colostomy. I know that was done oftentimes, but we do have evidence showing that protrusion above the skin reduces stoma complications. So for ileostomies, you want that protrusion to be at least 2 centimeters if possible. For colostomies, you want it to be at least 1 centimeter. So I brook both ileostomies and colostomies to allow that protrusion. The short height, again, is associated with retraction, poor sealing of the bag, so you get leaking, stomal dermatitis. Now, there are some circumstances, it's easy for me to say, just pull it up above the skin. But oftentimes in real life, that's harder to do. There are scenarios that make that seemingly impossible. That could be a very large person. That could be foreshortened mesentery. Usually those coincide, it seems. And not to say that because I'm big, so no one can have it. And then you can also have Crohn's or some kind of malignancy tethering that mesentery. So some of the things you can do to help that reach, and I find that this is really one of the main things driving the stomal complications, in my opinion, is the difficult stoma to get up and protruding above the skin without tension. So things that I typically do: mobilization. People try and get away with not mobilizing enough, and it causes retraction, and that's going to cause stenosis, mucocutaneous separation, ischemia, and to me, that's one of the biggest deals: mobilization. Also, when you're mobilizing, you want to try and not take the mesentery so that the tip that you're going to brook becomes ischemic. So those are 2 huge things. Other things you can do: in-loop colostomy or in-loop, ostomy, upper abdominal site, typically less thick of an abdominal wall, so it's usually you're able to pull it through easier, and selective mesenteric vessel ligation, which really is part of mobilization. You can also do things called pie crusting of the mesentery. I've not found that as efficacious as some of the other things. So rod or no rod, you need to put a rod in whenever you're doing a loop stoma. The short answer is no, with a caveat of there have not been any studies done on whether a rod is helpful in obese patients. So pretty much all the studies that have been done have been patients who are in BMI category that's not obese, and usually those are the patients that you are worried about retraction on. So in my practice, I do not routinely place a rod. I think it usually creates more trouble for necrosis of the bridge between the diverting villi, between the orifices of the loop ostomy, and makes pouching difficult for the patient. And with ostomy care nurses, it increases stoma dermatitis, peristomal dermatitis. So yeah, there have been studies done. These are on non-obese patients, showing no difference in retraction, stoma necrosis, peristomal dermatitis, but again, we don't have that data on obese patients. But I'm a selective rodder, only in obese patients where I can't mobilize more, and I'm a little worried about retraction. Next, mesh or no mesh. Whenever you're creating ostomy, and most of the data we have is when you're creating an end colostomy, whether you should put a prophylactic mesh there to try and prevent peristomal hernia. The short answer is right now in our clinical practice guidelines, the answer is no. There have been different randomized controlled trials and meta-analyses that have given us different answers to that, but the data is not convincing enough, and that it's also heterogeneous enough that at this time we do not recommend prophylactic mesh placement at the time of end colostomy creation.
1 minute.
Okay, thank you. One thing that may help reduce the prolapse rate or the peristomal hernia rate is tunneling. Once you come through the fascia, you can tunnel the ostomy in the subcutaneous tissue. I have not utilized this yet, but that is something that I'll be looking more into because it has shown a significantly lower rate of peristomal hernia prolapse. Mobilization we've talked about. Perioperative care pathway, these are mainly for ileostomies. I tell all of them if they have more than 1 liter of output a day, then to call my office and I'll get them started on fiber, thickening snacks, or Imodium or Lamodal to prevent readmission from dehydration. And I tell every diverting loop ileostomy that, and it does save readmission rates. How do you evaluate for closure of diverting loop ileostomy in the setting of a colorectal anastomosis? You can do a water-soluble contrast enema. You can do proctoscopy, you can do digital rectal exam, you can do a flex sig. Hadn't been shown that any of these are really better than the other. I typically do a water-soluble contrast enema if it's a upper colorectal anastomosis. If it's lower, I'll do a VRE and a flex sig. Because the balloon for a contrast enema usually traverses my anastomosis in those low anastomosis cases. Early closure versus delayed closure. You can do a closure within 2 weeks or after 8 weeks is pretty much the sum of that. How do you close the diverting loop ileostomy? Staple door hand sewn. No big differences there except hand sewn you have a little increased risk of small bowel obstruction. How do you close the skin? Actually, a purse string supplage closure has less infection and a greater patient cosmesis score. That's it. Did I make it? Was I close?
You're late, but this paper is open for questions.
I was just wondering, hi, I'm in Sweetwater, your little neighbor to the south.
Awesome.
Tracy, can you use the microphone just behind you?
Oh, shoot, really?
Sorry.
I don't have, as you know, it's not on.
It's on.
Hello? Okay. As you know, we're really tiny. I don't have the luxury of ostomy nurse or anything like that. They come to me for troubleshooting and education. I was just wondering what pros you have for that preoperative education for the ostomy.
Really a packet of what kind of ostomy you're going to use on them. So whether it's a Hollister or a coloplast, stuff or a bag that you're going to create for them, I would go over how they're going to change it, how they're going to measure it. So I would go through that bag with them. Also, you can go to those websites and they will give you pre-op education packets that you can go over with the patient. So I would order those. Yeah.
Dr. Ron from Omaha. I mostly take care of patients with melanoma, and one of our big complications is lymphedema. And the best way to avoid lymphedema is not to look at that thing. So, kind of, and a similar question is a best way to avoid ostomy complications, presumably, is not to perform an ostomy. So, are you more aggressive about not performing ostomies now, particularly with regards to low anastomosis in particular? What is the decision making that you go through?
Yeah, I would say it's complex and individualized. I probably go through a little waxes and wanes. There are some times when I am on a streak of very, very good outcomes with low anastomoses, and and I will be a little more aggressive in not creating a protective diverting loop ileostomy in that setting. And then, if a leak happens, then it'll scare me back into doing a diverting loop ileostomy. So but the factors that go into it, if I'm within 8 to 10 centimeters of the anal verge with my connection, then typically I will do a diverting loop ileostomy because the risk of leak at that point is higher than I'm comfortable with. And a lot of times on the patients I'm doing these on, the rectal cancer patients who have been chemo and radiation. If they have radiation down there, I'm going to do a diverting loop ileostomy. If they have Kissimmee diverticulitis, I'm typically going to do a ostomy.
You got a short one, Cal.
There are other ones too, but I just can't go into all the scenarios that would make me do it.
So my first question is a quick one. How long do you leave your rod in when you put it in?
So I can go ahead and answer that. Yeah. I typically, when I do put a rod in, I take it out at the day of their discharge. So typically 3 to 4 days.
Second one's a very tough one. When do you do the how do you call it, preemptive mesh placement in any of these ostomies?
I don't do prophylactic mesh placement.
Thanks.
Because a lot of the ones I do, I plan on taking.
Thank you, Dr. Kidwell.
Thank you.
Our speakers, if you guys just want to take your microphones off, you're missing all the presentations. I don't know why they did this, but you don't have to. Let me just go take your microphones off and just listen to that. You miss all the good stuff. All right, and for the audience, we have several minutes at the end to ask more questions. So our next presenter is Dr. Erna Tanchu. She's has come all the way from Bentonville, Arkansas, and she's going to be talking about lower GI bleeding.
Good morning, everyone. I guess a fun topic about lower GI bleed. This is my financial disclosure today. I'm going to start, this is going to be the content of my topic, really defining what we call lower GI bleeds. I'm going to touch on a little bit on the epidemiology, the causes, and how do you really kind of present these patients, manage them, diagnose them, and all that. So how do you define lower GI bleed? It's really any bleeding past the ligament trites. That's what we call lower GI bleed, and it can go from a small amount of bleeding on the toilet paper to toilet bowl filling it with blood from diverticular bleed. Usually when you have bleeding, it can be ongoing, but if it's intermittent, it can make it a little challenging to diagnose and to manage. We consider massive colonic bleeding when you have requirements of more than 6 units per aggregate requirement, which we'll talk about in a little bit. A little bit on the epidemiology. I mean, lower GI bleed is a pretty big topic. It accounts for about 1.7 million office visits in 2009 is what was documented. And your incidence of hospitalization for lower GI bleed, 0.02, 2.7%. It does feel sometimes like it's a little bit more than that because that does count for a lot of my office visits. Incidence of lower GI bleed, as we can all imagine, it is higher. The older you are, usually above 60, has a higher risk factor for lower GI bleed. Male, plus or minus more than females. Race hasn't really been proven to be a factor, but African Americans do have a higher incidence of diverticular bleed than Caucasians, not quite sure why. And really, we're going to kind of veer into the different causes of lower GI bleed, which I think is the crux of this topic. Diverticular disease, that's the most common cause of lower GI bleed when you kind of take away the rectal etiology. It happens because of pseudo-diverticular areas of weakness in the colonic wall. That's where the vasorecta intramural branches of the marginal artery cross through the muscular layers. So that's kind of how you have your bleeding. It's the most common cause that we see in the hospital usually. Colonoscopy is how you diagnose it. And colonoscopy is also pretty good because you can also either see active bleeding from a diverticular or stigmatic bleeding, like a visible blood vessel or an adherent clot, a visible vessel or an adherent clot. These patients usually present with painless hematochezia. Diverticular bleeds usually are right-sided more so than left-sided. The left-sided diverticular bleed, I probably haven't seen much of those. Usually, about 80% of the time, they're resolved spontaneously. By the time they call the consult, usually is when they have resolved. But the rebleeding rate can be as high as 40%. Anorectal is a big reason why I see these patients in the office. The most common is hemorrhoids, and everybody thinks that they have hemorrhoids, more particularly internal hemorrhoids, right? Your internal hemorrhoid bleeding is going to be the bleeder that's frightening all the patients. It's kind of filling up the toilet bowl. It's painless, and they think that they're dying. You know, fissure bleeding are probably usually the ones that are on the toilet paper. Their wiping is not so much that impressive. And then you have your other causes of bleeding, like if the patient has had radiation for prostate cancer a while ago and they have some proctitis, they can bleed from that. They can have ulcers from like STDs, anorectal trauma, NSAIDs, or the most frightening one of those for me is rectal varices with these patients that have really liver disease. And I say frightening because everybody thinks they're hemorrhoids, but they're varices, and please do not bend them in the office. The next cause, which is a little bit more subtle and less common, is intradysplasia or your AVMs. These are most common in the cecum in the right side of the colon. The most important risk factor with that is age. And what tends to happen is that there's a malobstruction of the submucosal veins traversing the colonic walls, and that results in the incompetency of the precapillary sphincters, and that produces small arteriovenous communication and subsequent dilation. These patients usually present with a cold bleeding. They have melena, they have painless bleeding as well. Other factors that increase the risk of AVMs are comorbid conditions. These patients that have multiple medical problems, patients that are on antiplatelet therapy or anticoagulant. And this is what they look like on colonoscopy. Malignancy, not as common. It's less than 10% of patients with malignancy will have lower GI bleed. The sequel and the right side are usually present with a clot bleeder. These are the patients that you'll see for anemia, but not necessarily blood loss. The left-sided and rectal lesions are the ones that will present more with blood correcting when you're talking about malignancy. Ischemic colitis, my most favorite consultation as a surgical resident in the ICU. These are the patients, they will present with lower GI bleed. The bleeding is usually because of the perfusion of the ischemic segment of bowel. Most common areas where this is affected is Griffith's Point and Siddick's Point, which are the watershed areas. These patients will usually have abdominal pain, some cramping, tenderness to the left side, bloody diarrhea, urgency to defecate. These are the patients sometimes are kind of in the ICU, have been there for a while. They have AFib, and all of a sudden start having abdominal pain, start having lower GI bleed. Those are the consults that probably sound familiar to the surgical residents in the room. But, and you know, or the patients that have low flow state for whatever reason. The risk factors with ischemic colitis are elderly patients, patients that have multiple comorbidities. It's usually, the bleeding is usually less severe. It's not like as frightening, but it is bleeding. Blood transfusion is rarely necessary. The patterns of ischemia is usually all or nothing. It's either pancolonic or it's just more right-sided. These patients are at risk for reversible ischemia though, so we do need to pay attention to them because they can develop bowel necrosis, obviously, and require surgical intervention. If you do end up having to take a patient with ischemic colitis to the operating room for surgery, their mortality rate is pretty high at that point. And then we have these other causes of rectal bleeding. Post-colopectomy bleeding, for those of us that do colonoscopy, is kind of one of those things that's really annoying when you get that phone call after you've done a colonoscopy. Because most of the time they'll just stop on their own. Sometimes they don't. The other cause, which is also annoying, is anastomach bleeding. I just had one last week for a right colon. You know, it makes you a little annoyed more than anything because again, they're also mostly stopped by the aneuploidy cells. And then you have the GI exciter ones, the inflammatory bowel disease. Those are the patients with Crohn's and also colitis. Patients with HIV and AIDS can have CMV colitis and do have bleeding from that. Patients that have abused NSAIDs, or patients that have rectal injury, whether from radiation or from trauma. Now we're going to talk about sort of like the next few slides is going to mesh all of that, like clinical presentation, management, diagnosis, and everything. So if you have a patient that's showing up with syncope, chest pain, pallor, shortness of breath, your hemodynamic unstable, that's the first thing you want to do before you kind of continue with your treatment tray or diagnostic tray is stabilize them. So 2 large bore IVs, you go back to your ABCs, plus or minus blood transfusion, continuous vital sign monitoring, put a Foley, anti-tubac spray to make sure that they don't have a GI bleed or upper GI or upper source. Then you focus on thorough history. Just like with anything in medicine, you have to take a really good history. And I cannot impress upon this more because a lot of times when we go back to trying to identify the source, we could have gotten all the tests in the world, but a good thorough history taken will really usually guide you toward where the bleeding is coming from. What you're looking for is how often they're bleeding. What is it exactly? Is it that how much is bleeding? How many times a day are they bleeding? Do they have any comorbid conditions? Are they on any anticoagulations? When was their last colonoscopy, which is a big one? You'll be surprised how many people forget to ask the patient when's the last time you had a colonoscopy. So that's really important to find out. And then you have to do a focused physical exam. Assessing the signs and symptoms, like I said earlier, make sure that they're stable. Then a focused abdominal exam, you're looking for abdominal pain, you're looking for whether or not their belly is soft, if they have some tenderness, where exactly is their tenderness, if they have any sign of chronic liver disease, like the FMC caput medusa, which are here to see, but you're looking for jaundice and things like that. And then the rectal exam. From a colorectal surgeon, anything that has a butt and a finger, you can examine. Again, this rectal exam will give you all the information that you need as far as like eliminating an interrectal etiology. So when you're doing a rectal exam also, you're not just looking at the butt and that's it. You want to visually assess for a fissure, you want to visually assess for external hemorrhage. When you're feeling with your finger, you're feeling for a mass or any abnormalities that you can appreciate. And then you have to perform an endoscopy. I have my little portable endoscopies in my car, in my office, everywhere, because if you need one, I will take a look. But you are looking for internal hemorrhage, you are looking for stigmatic bleeding. We can sometimes give you a little appreciation of whether or not there's radiation proctitis, even if you don't go very hard on it. Obviously, you want to obtain labs to assess the hemoglobin and everything. And like we talked about, the initial management is following resuscitation, right? If they're hypotensive, we transfuse them. I'm a believer, if you're bleeding, you get blood. And if you get blood, you don't get 1 unit, you get at least 2. That's just my personal practice. If you need multiple units of pyruvate cell, then that's when you start to think about whether you need to add some platelets, some FFP to avoid dilution or coagulopathy. Now, patients that present with self-limited lower GI bleed, usually those are the patients that you'll perform a colonoscopy on. The major advantage of doing a colonoscopy is that it can be both diagnostic and therapeutic. And there is a debate about versus doing early versus semi-elective colonoscopy. I usually do them within 24 hours. Because there really hasn't been any decrease in diagnostic or therapeutic intervention or the number of transfusion or length of stay, whether you do them early or you wait a little bit. So colonoscopies. So about 95%, up to 95% of the time, you can identify your source in your colon. I usually do them within the first 24 hours. I have the patient do a rapid bowel prep, and I get it done. It helps because you can do intervention like heater probes. You can stop it with some epinephrine injection. You can put some clips, especially for the anastomotic bleed. If you do tattoo, that can be really helpful to identify the site of bleeding, especially if this is someone that can re-bleed and you have to go back. RBC scan or radionuclide scintigraphy, these are more diagnostic, they're not therapeutic. This is for major self-limited bleeder, and those are for the patient that are stable to radiology. You can detect bleeding as slow as 0.04 to 0.05 cubic centimeter per minute. You can also restudy it if the patient bleeds within 24 hours. There is a lot of variability with RBC scan though, so they're mostly used for screening studies before you perform a CT angiogram, and not so much as something that's going to make the decision on whether to take the patient to the operating room. This is what they usually look like. CT angiography is really supplanted RBC scan. I mean, we get this almost on anybody that has lower GI bleed. It's really become an initial means to evaluate patients with lower GI bleed. And this is for the patient that obviously don't have renal insufficiency, which is a contraindication or that are ready to die. If a patient has a positive CTA, those are the ones that then you send for angiography for embolization, or you decide whether or not they need a targeted surgical resection. It can detect bleeding as low as 0.3 ml per minute. And it's really been found that early colonoscopy plus a CTA most of the time, about 90% and more of the time, will help you determine and detect the source of bleeding. Angiography is really started to kind of take over as far as like how to manage lower GI bleed. This is for brisk bleeding. It's for the bleeders that are bleeding a little faster than the nuclear scintigraphy can pick up. The goal is to localize endorectal therapy. Used to be transcatheter vasopressin infusion was the way to do it with these large bore catheter. However, there was concern, or there was noticed to have a little bit more ischemia of the valve that was found. So there's been a lot of improvement in this realm with microcatheters that is allowing a super selective embolization, which is why this has really gotten to take off. And they use microcoils, gel foam and all that stuff. Our IR guys are really great at this super selective embolization. And this slide is pretty much, I think it's really a good summary because it's basically talks about everything I just talked about. I think it's one of the most important slides. When you have a patient with massive GI bleed, again, you kind of do an exam, you examine them. If you do find an anorectal pathology, you treat that. If you don't find any anorectal pathology, if it's massive cephalonitis, you get them prepped very rapidly for colonoscopy. If the bleeding is massive, it's ongoing, you get them to CT angio or directly to angiography. If you are able to self-localize the bleeder, you embolize it. If you can't localize it, you send them to surgery. If you have a massive bleeder that you can't stabilize, they go to surgery. Now let's talk about surgery. Now surgery in the setting of lower GI bleed is really for the hemodynamic unstable patient. It's for the patient that is continuously bleeding, that's unresponsive to initial resuscitation, or the patient that you can't find a localized source, or you find a source that the intervention fails. Or for those that needs more than 6 units of palliative cell over the last 24 minutes, or the next 24 hours. So when we talk about surgery, an expiratory operotomy, I don't think this is the time to do robotic or laparoscopic cases. If the patient is stable, you can do an on-table colonoscopy and lavage and identify it then. I have yet to do it because I think if you're going there, you're getting a cut. If the patient is unstable, or the source cannot be identified, or there's any rule out source in the stomach, the anorectal area, those patients get a total abdominal colectomy and aneuploidy. If you have a patient who has had bleeder that's been identified, but they failed the intervention, those are the patients that you would offer segmental resection, plus or minus an anastomosis. I personally not anastomosis lower GI bleed. It's a little silly. If you're going, you get a colostomy. And that's pretty much it. Again, this is the slide that this is also a really good slide to help with that algorithm. Thank you.
Excellent talk. There's a microphone right in the middle of the aisle here. If anybody has any question, please proceed to the aisle.
What do you do for a flash bowel prep or a quick bowel prep?
So
that rapid bowel prep, what do you do?
Oh, golightly. I either do golightly, I give them to them because they'll never finish it. They'll get sick, so they'll be able to get at least half of the golightly. Or I do like 250 grams of Miralax. And
over what time period?
Over 24 hours.
Oh.
Yeah, so I'll see them, I'll get them started with the bowel prep. They'll throw up about half of it, but by the next day, I'll be able to see something. But if I'm successful, at least you're able to get them quickly.
Neil, for the ischemic colitis, do you always scope them before you do an operation?
And then, we use it golightly because it doesn't really change the fluid volume or the status of the patient because it doesn't add or remove fluid. So to me, that's probably the safest bowel prep anyone can use.
Tastes like crap. I've tasted it.
I'm Allison Blumen, I'm a resident from the University of South Dakota. My question is something we get consulted on pretty often, which is rectal varicose bleedings and how you manage that.
So I say call someone else. But in all honesty, rectal varices really just shows you how bad the liver disease is, and that's really what they should focus on, is what I usually tell the GI doctors, because you can't bend them. Taking them for surgery would just get you stuck in a loop that you can't get out of. So usually they have portal hypertension. Those are the patients that may need tips, they may need more liver calls, but I usually tell the those people that are consulting me that manage their liver disease and, really transfuse them.
Yeah, I always say tips.
Yeah, tips.
And for those rectal varices, sometimes you don't want to be there. But if you have to, then you put a bunch of volume with stitches. I've been there once and it's not fun at all.
Siva Vidyanath in Cambridge, Massachusetts. I was wondering whether you have any information on newer technology in terms of improper diagnosis of site rather than doing colectomy if you're not sure where things are going. Is like indeciding bleed, is there a role for that in bleeding, not perfusion?
So ICG, well, I guess to start your question, when I take them to the operating room, it really depends on why I've taken them, right? So if they're unstable and they're on the operating room table, they're gonna get a total abdominal colectomy because they're unstable. But if I have sometimes they're stable and it's one of those things that you get an angio and you can't find where the bleed is, those are the patients that I'll do an on-table colonoscopy and I'll do a lavage at that time because if they're in the operating room I can see. If at that point in time I can identify the bleeder or visible areas of bleeder or I have an inkling as to where the bleeder is, if they are stable, I have done segmental resection and they're done fine. ICG, I've not used it in the setting of identifying lower GI bleed. I'm not sure it would work just because the way the technology is made, it will show you bleed like a well-perfused bowel. It won't really show you a bleeder, if that makes sense. It will show you.
Based on where it lights up first, right? If you have so much blood. I'm just curious.
Yeah, I haven't used it. I don't think it would be helpful in that setting because I think that everything would light up and it might end up being confusing.
Thank you for that educational talk, Tammy from Sioux Falls. Do you ever use, what's the role of transanal hemorrhoidal Doppler ligation or any of those technologies? Because still the hemorrhoidectomy is the standard.
So I mean, I think that it's really a great technology. I personally don't do it in my practice. I have heard about it. I've seen some colleagues that do it and they have really, really good results. What I do is I do rubber banding for internal hemorrhoids. If I have a patient that has internal hemorrhoids that are bleeding, I do rubber band ligation. There hasn't been a lot of data that shows that transdoppler ligation is better than rubber banding or is better than hemorrhoidectomy. There has been some data about it's better as far as postoperative pain, which if you rubber band, they don't really have as much pain. So I haven't felt the need to transfer, but it's good practice and good results.
I think maybe 30 more seconds, but by show of hands, who has done total abdominal colectomy for bleeding recently? And who plays call first? You, interventional radiologist, or GI doctor?
We don't have anything but me.
No IR.
So
No.
what about GI? Who gets called first? Colon surgeon first? Yeah, so in my hospital, I've had the algorithm nicely done that I get called last. So by the time I'm involved, the patient definitely needs surgery. So, all right.
Family practice and me and family practice ain't doing this.
What interesting time. We're gonna move on. The next presenter is Dr. Isikak Omo. He comes from Houston, Texas. He's with the Woodlands Colorectal Associates, private practice. He's going to be talking about rectal prolapse. Help, my rectum is falling out.
Good morning, everyone. I'm Isikak Omo, colorectal surgery in Houston, and I appreciate the opportunity to talk about this topic, rectal prolapse. And I'll be talking about it in the context of colorectal emergencies. I have no financial disclosures. So So I'm going to start off with a typical presentation, maybe not typical, but a presentation that was seen, in case reports. A 52-year-old male can present to the emergency room with 2 days history of an irreducible rectal prolapse, past history of a rectal prolapse requiring minor reduction. And on examination, they found a full thickness rectal prolapse and evidence of mucosal necrosis. Now, this can be a typical emergent presentation for a rectal prolapse. We'll go by a few definitions before we come back. So, rectal prolapse refers to a full thickness intersusception of the rectal wall through the anus. Now, you can have a rectal mucosal prolapse, which is different from a full thickness prolapse, just mainly because rectal mucosal prolapse has just the submucosa and mucosa involved, and the treatment is a bit different. Now, a few anatomic associations with rectal prolapse include deep cul-de-sac, heartless anus. That's when these patients have incontinence. They have diastasis of the levator ani, redundant sigmoid colon in many cases, and loss of attenuation of the rectosacral attachments. It is a rare presentation, particularly in an emergency setting. But you can see it occasionally occurring about 0.5% of the time. Females more affected than males, and elderly, obviously. For men, it tends to be a little earlier than for women, and more than half of the people have associated fecal incontinence, but a good proportion of people also have constipation. And it's important to identify who has what, and that might tailor the treatment appropriately as well. Rectal prolapse is largely diagnosed clinically. You see basically, you have these concentric rings of prolapsing tissue around the anus that kind of gives it away as full rectal prolapse. And you have to differentiate this from other things such as grade 4, internal hemorrhoids or prolapsing internal and external hemorrhoids. The key important thing is establishing a good history. During the history, understanding the patient has constipation, fecal incontinence, understand the comorbidities the patient has as to what kind of surgeries the person is going to be able to tolerate. And further workup, including a colonoscopy, if you can have the time to do that, is important. Because sometimes in rectal prolapse, you have a lead point, which might be a tumor, very rarely. And so establishing that before surgery is important. Epicardiography may be needed in some instances. This is just a picture of what you might also see or be called up from the emergency room when they tell you that the patient comes in here with rectal prolapse. You go examine the patient, and you have to make sure that you're not dealing with hemorrhoids. So internal prolapse and hemorrhoids, we tend to have more of radial prolapse in tissue as opposed to the concentric tissue that we see as in the previous slide with the rectal prolapse. So how do the patients present in the emergency room? So in the emergency room, you have 3 basic presentations. So they either come in with a rectal prolapse that is reducible, it's not incarcerated, not irreducible, and they call usually these patients just have it for the first time and they're worried, they're concerned, they go straight to the emergency room. This can be treated electively. The other presentations are irreducible rectal prolapse. So this can either be incarcerated without evidence of vascular compromise or strangulated, in which case you have evidence of vascular compromise. In the emergency room, what are the measures you can take? So for the incarcerated rectal prolapse, the first step, in my opinion, is to try and reduce the prolapse if you can. Switch it from something emergent to something more elective or semi-elective if possible. If you cannot reduce it, you have to try applying some hypoosmotic agents, which the most common is application of sugar, and that sometimes reduces the edema and allows it to get reduced. And if you can't, then you should plan reduction under anesthesia, or the patient might require emergency surgery. For a strangulated rectal prolapse, because of the vascular compromise, necrosis involved, these patients should not be attempted on renal reduction. You should take them straight to the operating room. The goals of treatment will be to eliminate the prolapse either by resection or restoration of the normal anatomy, correct the functional abnormalities, including the fecal incontinence and constipation if you can. And while doing that, try to avoid creating another problem for the patient in terms of bowel dysfunction. What are your options in surgery? So you take the patient to the OR, patient has an irreducible rectal prolapse, is still incarcerated, you put the patient under anesthesia. And what happens sometimes, and it's happened to me, is Immediately the patient is completely asleep, it reduces. Well, that's not a bad thing. So now you have a situation where you have a plethora of options to choose from. You can either deal with this as an immediate problem, where you do whatever surgery you want to do, whether it's abdominal approach or perineal approach, or you can make it a semi-elective problem where you actually let the patient have some resolution of the edema over, say, 72 hours, prep the patient, do a colonoscopy, and plan a procedure afterwards. Now, the options you have in this situation will include an abdominal approach, such as you have with posterior rectopexy, you can do a resection rectopexy, ventral mesh rectopexy, or some abdominal approach, some perineal approaches, such as the Delorme's procedure, which is usually for shorter prolapses, and then you have the Altmaier's procedure. If you still have an incarcerated rectal prolapse and it's not reducible just by the anesthesia, I think your major option that you have is really just a perineal proper sigmoidectomy, otherwise known as the Altmaier's procedure. For a strangulated rectal prolapse, I wouldn't attempt to reduce it. I would just proceed because you have to excise the area of vascular compromise, so I would proceed with an Altmaier's procedure. Now, based on surgeon's preference, you may or may not decide to do an ostomy. Now, I'm going to say a few words on the Altmaier procedure because I think this is what you might need, more importantly, in a very emergent situation, particularly in the setting of a strangulated rectal prolapse. Positioning, this is all surgeon's preference. You can do it prone or you can do it without. I personally do most of my things prone. You exteriorize the prolapsing tissue, proceed with marking circumferentially proximal to the dentate line, usually about 1 centimeter proximal, and then on one of the sides you do a full thickness proctotomy, and subsequently go around it and then reduce the entire prolapse as much as you can, trying to stay just along the bowel wall if possible. Once you get to the anterior peritoneal reflection, you can make an incision on that. That allows you to reduce the rest of the sigmoid colon as much as possible until you get a little tension, but not too much. And then you proceed with division of the mesentery. If these patients have evidence of pre-existing fecal incontinence, you may want to consider posterior levatoplasty as well, just to tighten it up a bit. When you do that, just make sure you still have about a finger's breadth so it's not too tight on the bowel. And then you can go ahead with your resection systematically and creation of your coloanal anastomosis. So back to the case report, what the authors did for this prolapse was, I guess because of the presence of mucosal necrosis, they proceeded with an Altmaier's procedure, and they did a diverted colostomy, which I think is a reasonable approach, a safe approach. The outcome was good. In conclusion, so rectal prolapse is important, but it is rare as a colorectal emergency. Diagnosis is largely clinical. Key is to really differentiate this from prolapse in internal and external hemorrhoids. And I think one of the surgeries that would be ideal for people to know, particularly in the setting of incarcerated and strangulated rectal prolapse, would be the Altmaier's procedure. All right, thank you very much.
This paper is open for questions.
Hi, I've seen 2 consults already, where I'm second year now, and I tried personally sugar and it doesn't work. Have you seen it work? That's my first question. And then the second one is, how do you think it's strangulated? Is it by the color? Is it when it looks dusky? Is it like lactate level? Is it like some high on the CAT scan? So these are.
Yeah, good questions. Yeah, the sugar does work. So, you know, I've used it once or twice in my career, and it does work. You know, you see, I just generously apply the sugar over it, and you actually see some of the whipping, and edema goes down, and then you just try to gently reduce it. If you're in the ER, a little relaxation also helps, and you can, so it does work, but it doesn't work all the time. But at least it's something to try. The second question was on...
how do you know it's incarcerated?
Yeah, incarcerated. So basically, it's evidence of ischemia, so it looks dusky, necrosis, basically evidence of vascular compromise.
I was just wondering, so if I'm at my little hospital, I take them to the OR and I get it manually reduced under anesthesia, what is the timing I need to get them to you guys?
Yes, good question. So usually if the patient requires manual anesthesia, manual reduction under anesthesia. I personally try to get it done while you're in the hospital within 72 hours. So that just buys me more time to get it down. And then, I get worried initially the first few times I did it. I was worried whether they're gonna just prolapse again on the floor, but they don't really prolapse again on the floor. Usually you're able to get 3-4 days out of it without a problem. So I think if you manually reduce it and you want to send it out, I think it should be fine. I think once the edema goes down, it should be okay.
I'm sorry, I'm a gynecologist, so I apologize. What kind of sugar do you use? Brown sugar, white sugar?
I just use white sugar. Sugar on the floor. I just ask the ER for sugar. They get some sugar, and we just like to get packets and just like pour it all over it. And then I use a warm towel, and then just wrap it around the warm towel.
Sugar works. You didn't put enough sugar.
I'm Sharik Nazir, one of the pediatric surgeons from New York City. So actually, when I used to take a call for the acute care surgery, we used to use hypertonic saline, which is called mannitol. What it does is it reduces the edema. So you can use for paraphimosis, you can use for prolapsed ostomy also, and prolapse as well. So just a quick question, what do you do when you see a prolapsed ostomy? Same treatment?
Yeah,
it's different than prolapsed rectum. If the patient comes with a prolapsed ostomy, what will the treatment modality is?
Yeah, so prolapse ostomy, that's an interesting one. So the way I approach a prolapse ostomy, usually they are not incarcerated most of the time, right? But they can be incarcerated. And if they're incarcerated, you treat them basically with the same algorithm. I try to reduce it. If you can't reduce, basically we go locally and actually almost like an all-eye procedure, just go around it and re-trim it again down. But again, if the patient, one of the things about prolapse ostomies is they tend to recur a little more because it's just an ostomy. Especially this tends to happen more with the colostomies, right? So what I would say is, if the patient can get it reversed, then I start planning towards the reversal of the ostomy as a definitive procedure. But yes, the treatment will be conceptually the same. Reduce it if you can reduce it. If you can't reduce it, then you go. I personally go locally and transect. I don't know what the other colorectal surgeons do, but that's what I do.
I have a question if nobody else does. So the sugar does work. Yeah, you just make sure. Sometimes I have the family members go and buy the whole bag of sugar and just pour it on there. You just gotta leave it on there for a lengthy amount of time to let the edema go down. And obviously you gotta know how to reduce the prolapse. There's a technique to that. It's just not pushing. You just gotta fold it in and until you get it in. So that's why oftentimes people don't know how to reduce that. One question. I think for the general surgeons, there's some general surgeons that actually dabble into doing prolapse surgery, and I think the key is ruling out a mass in the rectum. Because oftentimes I've seen rectal cancers get done, but there's no colonoscopy or flexible colonoscopy to rule out a mass, and then the patient will come back to us with a prolapse mass, a quick prolapse, and then the patient will be asking you what happened. So I've seen that a couple of times from outskirts general surgeons. So I think it's very, very important for a nice scope to rule out the mass. Dr. Kondylis, I still have a lot of minutes here. I think we have 2 more minutes. You've been doing this for 20-some years. Any comments?
Well, in regards to the sugar, I've had the experience where I've gone to the ER and they tell me the rectum is packed in sugar and about 5 sugar packets. If you're going to go sugar, you have to go 5-pound bag. Otherwise, don't bother. The good news is most of the time that I'm called that there's a incarcerated prolapse, it's not. It might be boggy, it might be edematous, but 70% of the time it's easily reducible. In the old days, the ER tried hard to reduce them. Now they just look. And they go. There's not a lot of effort to reduce it. The worst ones are when they come from the nursing home. Because the nursing home's been reducing it for 5 years. And they're skilled at it. If they can't reduce it, they're the kings of reduction. It's going to be hard for you to reduce it without going to the OR. But, and no, it's fortunately an uncommon problem, but the only good thing is that an Altmaier is a beautiful operation. It's a pleasure to do it. You have to remember to caution folks that the prolapse has been a cork in the bottom, and they may have been constipated for years, but fixing the prolapse is getting rid of the cork. So in all likelihood, they're going to have some degree of incontinence, and all these patients need sphincter reconditioning and rehabilitation afterwards.
Any other questions? Okay, thank you. So, we are doing really well on time here. Excellent speakers, made on time, and fun directions. While they prepare Dr. Izzy Obohari here, Dr. Izzy Obohari comes from Amarillo, Texas. He has, again, another Texan in the house. He's going to be talking about the current management of complicated sigmoid diverticulitis.
Thank you for that introduction, and thank you to the moderators for inviting me to speak on this topic that we all face as general surgeons, diverticulitis. This is my only disclosure, and it has no relevance to the talk today. So now let's define some terms. Diverticulosis is just really outpouching in the wall of the colon. While diverticulitis, on the other hand, it's an inflammation. As you can see here, I don't have a mouse, but at the top right of the screen with the small arrow, that is diverticulitis. The others, the dark arrows, are the diverticulosis. So diverticulitis is just an inflammation. Now, what makes it complicated? I'm going to focus on that. I'm going to zero in on that. Now, that definition has kind of moved a little bit. But this is when the patient has a large pelvic abscess. Hepatic abscess can also recur from diverticulitis, or fistula formation. From coloenteric fistula to colovesicular fistula, which is the ones we see most common. Colofallopian fistulas is also present as well. In fact, I just did a case late last year, and we're publishing that on a colofallopian fistula. Colovaginal fistula is very disturbing. Most patients come and complain about that as well. But some other complications like a colocutaneous fistula can occur with chronic diverticulitis. I think one of the worst ones I've seen is a coloperineal fistula. So this is a gentleman that had, we'll talk about it in the case study here. As well as perforation, of course, sepsis, which is the common one we see in the ICU. Stenosis, which is for patients that have chronic diverticulitis. I call them smoldering diverticulitis. So the colon cannot distend. As a result, they have pseudo-obstruction or they have a true obstruction. And of course, recurrent abdominal pain and, as mentioned, diverticular hemorrhage. Those are all complications for diverticulitis. But typically, diverticulitis does not bleed. Diverticulosis bleeds. Now, how do patients present? Okay, they can present from typically left lower quadrant abdominal pain, nausea, but usually absence of vomiting. Fever, sepsis, septic shock. The most common occurrence I get is a patient in the ICU with abdominal pain. Obstruction, of course, those patients usually come to the ER. And then those patients that see us in the clinic usually have those vague chronic abdominal pain. They tell you the pain comes after eating foods that are high fiber or hard to digest or red meat. And it occurs periodically. And it gets better after a bowel movement. So those patients are, I call them pending bowel obstruction. So you have to watch out for those. And usually the CAT scan is not very helpful in patients that present with vague symptoms like that. One of the questions you want to find out in the clinic or in the hospital is, do they have pneumoturia, which means air with urine? And the easy way to ask the patient this question is, does the urine bubble in the commode when they urinate? So it's a simple question. Or do they pass air when they urinate? Ficcuria is also another common one, or recurrent urinary tract infection. The patient with the fallopian fistula had recurrent vaginal infection. She did not have recurrent UTIs, but recurrent E. coli vaginal infection. So whenever they had a culture, she had it for about 2 years time frame. So that was what kind of keyed up to the diagnosis. Abdominal mass, of course, this is a patient that is 80 years old and looks pregnant. They may have a fistula to the uterus, okay? And it's a large stool ball in the uterus. And then you also have some very vague, unusual presentations with complicated diverticulitis. Now, how is the diagnosis made? Usually by CAT scan. History, physical, and then CAT scan. Ultrasound can be used as well, but the CAT scan has a higher sensitivity and specificity. How is the classification done? Or how do we determine the degree of complexity? Is done by a Hinchey classification. And the Hinchey classification is a radiology-based classification. So it's not based on the physical exam or based on any other factors or how sick the patient is. It's just based on the CT scan. For the purpose of this talk, I'm going to focus on Hinchey stage 3 and stage 4. Because Hinchey stage 1 and 2 are not really considered complicated diverticulitis. And the other thing about complicated diverticulitis is this. A patient with a Hinchey stage 1 or 2 could be complicated if they have a complicated medical history. Let me explain. If a patient with Hinchey stage 2 presents and they are on immunosuppressants, on steroids, they're on methotrexate for rheumatoid arthritis, they're receiving chemotherapy for another type of cancer, and present with stage 2, they can easily progress to stage 3 or stage 4. So those patients, I still consider them complicated, even though on CT scan it's the stage 2 diverticulitis. Now, how do we work them up? We talked about doing a colonoscopy, but usually a CT scan would suffice, or if the CT scan is equivocal, you can do a contrast study, like a gastrographin study. So this kind of tells you the difference between a colon cancer and diverticulitis. With diverticulitis or diverticular stricture, you'll find a long segment narrowing of the sigmoid colon, as opposed to cancer, which gives you the upper core lesion, which is very classic for cancer. So this is also another way to determine if a patient has cancer or diverticulitis, if you can scope them in a short-term period. But I like to do the CT scan. I think the CT scan is very helpful. It tells you the problem. As you can tell, the concern here is not just the perforation, but the size of the patient, okay? You look at this and you're like, the patient can't fit on the CAT scan. So that's gonna be a tough case because of the patient's body habits. Let's do a case study real quick. A 66-year-old male with abdominal pain, worse in the left lower quadrant, and had extensive perianal fistula. He had no prior colonoscopies. He smokes about 2 or 3 packs of cigarette a day and has smoked for 20 years. On examination, he has focal peritoneal signs, and look at his labs. He's malnourished, normal creatinine, and a white count of 6. But so the first thing we do is you get a history, physical exam, as we typically do, and of course you get a CAT scan. So you get a CAT scan, and the CAT scan shows this. Look at the colon on your right. You can see there's an obstructing lesion in the sigmoid colon. It's hard to tell if it's cancer or if it's diverticulitis. There's actually a shelf with dilated loops of colon. The small bowel appears normal because the ileocecal valve is competent. On the CAT scan on your right, you can see the patient has large perianal fistula as well. So this is a complicated case. Like, how do you approach this? Who do you call? And I got a call from one of my colleagues who was about to transfer the patient out to a tertiary care center. The GI doctor called him for the consult, and of course he called me and said, this is something I can't take care of. So this is a patient with a complicated diverticulitis. Okay. The differential will include Crohn's disease, will include colon cancer. Okay. So the differential is very broad. So I ended up had to decide what to do with this patient. So in my mind, I thought, okay, do I do this laparoscopic? Okay, robotic or open? How many people do it laparoscopic or minimum invasive in this room? Very good. Okay. There are a few bold tough people that will do it laparoscopic or robotic. Yes. So in this particular case, I looked at the lesion, the size of the lesion, the unprepped bowel, the need for intervention on this patient. This patient was hard to prep. And in fact, looking at this case, I decided to do it open because I realized this patient will need to get a colostomy. This patient will need to get a lot more done, and trying to make sure that this issue is taken care of very quickly. So I did an X-lap sigmoid colectomy. Of course, the left ureter was plastered against the side wall. Okay? So what are the pitfalls in this case? Number one, we talked about this earlier. Make sure you mark the patient. Okay? In fact, when I mark a patient, I mark the right side and the left side, just in case you have to do a ileostomy versus a colostomy. And wound care management. Okay, that has to be there. Nutrition, trying to optimize the patient as much as possible. The first speaker, Dr. Kondylis, mentioned something about doing a prehab. I think that's a very important concept for our patients. In addition to doing the ostomy education in the office, you want to make sure they have nutrition, physical activity, and overall well-being is ready for the surgery. I tell my patients, listen, surgery is like running a marathon. If you have to run a marathon next week, what do you need to do today to get ready for the marathon? And the answer is simple. Eat right, sleep well, take your multivitamins, and get some good nutrition. Okay, so that is very important for our patients. And in patients like this that have a complex diverticulitis, the ureter injury rate is extremely high. So for those patients, I put in stents 100% of the time. We're in a place where we don't have residents from urology to put in stents at our beck and call. So in my practice, I learned how to do stents. So I do stents for all my patients that have this kind of problem. Of course, you also worry about vascular injury. The injuries to the major vessels in that location is also very high. So watching out for that. Now, how do we really stage diverticulitis? There's some modifications to the initial imaging, such that includes clinical evaluation. Kaiser, Wesery, and of course Wexner has proposed a change in the initial staging system from stage 1 to 4 to adding 2A and 2B. And this kind of teases out a little bit. But when it comes to diverticulitis, hinge stage 2, the abscess can just be drained. If it's a small abscess, oral antibiotic can be sufficient. But if it's larger than 4 centimeters, it may need to be drained interventional with IR. So in a smaller hospital without IR, this needs to be transferred out. And the goal is to temporize the infection and come back later to fight another day. When it comes to hinge stage 3 and stage 4, you may not have that luxury. If the patient is septic or sick, performing a heartless procedure or laparoscopic lavage. So my personal experience with laparoscopic lavage is this. It all depends on the patient. If the patient has a good hemodynamic status, good protoplasm, you can get away with the lavage. But if a patient is on methotrexate, immunosuppressed, and septic, you're wasting your time. You're kicking the can down the road, you'll fail, and you may need to do a colostomy or do a surgery during the same output state. This is what it looks like. This is a nightmare for every surgeon. You open the belly, and of course you see a lot of infection, and you see everything is sucked down. What do you do? In a case like that, planning to take care of the initial infection and coming back to fight another day is the best way to treat it. So do not try to put the patient back together when the pelvis looks like this, okay? Because it's going to fail. Okay? Now, when it comes to laparoscopic lavage and laparoscopic intervention, there are several studies. Due to the time frame, I may not be able to discuss all of them. But there's the latest trial, the Lala trial, the Scandal trial, and the LAP9 trial. All of them point towards pushing more for laparoscopic intervention as opposed to open surgery. Because there is shorter length of stay in the hospital, there's quicker recovery, and of course, patients they do better overall. When it comes to surgical options, what options do we have? You have open surgery with resection, you have laparoscopic, which is drainage or resection, and of course you have the robotic surgery. Now, what are the differences? The open surgery, of course, is you get in, get out, but the patient stays in the hospital for a long time, okay? So you just put passion on the problems of the patient. And of course, wound infection and wound complications. With laparoscopic surgery, with diverticulitis, I found that it's a little bit more challenging, especially with complicated diverticulitis, just because of the difficulty controlling the thick mesentery. You end up having wrist pain and shoulder pain, okay? But robotic surgery, I think, is not just the wave of the future, but it's here and now. There's decreased conversions from robotic to open as opposed to laparoscopic to open. So if I have a patient that has a problem, I would consider getting away with robotic surgery with incisions like this and being able to take out this much colon robotically. So it's doable. It just has to do with your personal comfort style. Now, colonoscopies. We talked about this. Doing a colonoscopy after diverticulitis. On the last talk about rectal prolapse, I think it still has a good role. For a patient above the age of 45 without a prior colonoscopy, it is vital and crucial to ensure that you do a colonoscopy. The risk of cancer is about less than 2%. Okay. However, that's something you don't want to miss. So make sure you counsel your patient about getting a colonoscopy. If it's an emergency, just do the colonoscopy after, before planned reconnection. Now, when it comes to prophylactic sigmoid colectomy, who gets it? Now, when the patient is stable, the patient has just a single attack of diverticulitis, you can wait. But if they have recurrent episodes, you may want to consider doing a sigmoid colectomy. Now, according to the recommendation for the ASCARS, there was a recent paper published about the practice guidelines in 2025. There was a work done by Jason recently, Jason Hall, and talked about doing a colonoscopy after an attack of diverticulitis is recommended, but elective sigmoid colectomy for uncomplicated diverticulitis should be individualized. So if the patient is on immunosuppressant, septic, and undergoing treatment for a particular disease, you may want to consider doing an elective sigmoid colectomy. For my patients that travel a lot out of the country, I would recommend that earlier, because they may end up having an attack when they're out of the country. So everything has to be individualized. But if a patient has complicated diverticulitis, you want to consider doing surgery. Right? And of course, this is the only one that gets a grade 1A recommendation from the paper published. It's talking about minimal invasive surgery. It's better than open surgery. So if you have to choose, make sure you decide well. Now, what are the pitfalls to avoid as I come to the end of my talk? Number one, you want to optimize and drain the abscess. First of all, if the patient has an abscess, drain the abscess. Okay, minimal invasive approach is preferred. Okay, this is a picture of a patient that I'll be doing surgery on within the next couple of weeks. That is one part of the belly, by the way. That's one half of the abdomen. Okay. So that is a large parastoma hernia after diverticulitis. Had diverticulitis at an outside facility, had a leak post-op, had a colostomy, and we're here with this problem. So this will require a multidisciplinary approach with myself, my minimal invasive colleagues, and a bariatric surgeon, all at once. His BMI is about 45, okay? So this is gonna be one of those. So using stent placement, use them judiciously for cases like complicated diverticulitis. Because usually the trigon of the bladder, the ureter, is stuck to the diverticulitis. Colon extraction site, very well. I also use mesenteric angiography. Somebody mentioned using ICG. I think this is the perfect role for ICG, making sure that your vascular ends are well, your anastomosis is well vascularized. And also using the ERAS protocol. Prehabilitation, of course, with patient marking is crucial. This patient did not get an ostomy marking, you can tell. So this is going to be a complicated ostomy. Instead of doing a revision, we'll have to do the reanastomosis rather than moving the ostomy. Ostomy indication, of course, getting your GYN and urology colleagues available. Because if you have a fistula to the uterus, to the bladder, or to the vaginal cuff, it's always good to have them available rather than calling them intra-op at the last second. I'll stop here and take any questions.
I have one question to start off with. So the acute care surgery obviously is kind of a new paradigm for the last 5 or 10 years. We've had a battle with our colorectal surgeons at the hospital where there is a reluctance to take on colorectal emergencies, particularly in the off hours. Actually, they don't take any during the course of the day, they do just elective surgery. So I noticed, and I've seen my colorectal colleagues do stent placement. I mean, I was kind of surprised that it was the colorectal surgeon that was doing stent placements, not the urologist. And I can understand the practicality of that because you can never find a urologist, when you need them to do stents.
Yes.
But now you have the acute care surgeons that are doing this, and I don't think any of my colleagues, nor have I, done stents. So, I mean, how can we support that? I guess Well, can you comment on that?
Absolutely. So my training to get stents in my facility came as a result of that problem. Because most times you have to do a sigmoid colectomy. It's off hours, usually at 2 a.m. or 3 a.m. or even at 11 o'clock. And they're busy, they're in the office, and they can't break out and come and do one stent and go back. So what I end up doing is having a talk with my urology colleagues and getting them to buy in. And they actually proctored me to do stents. So I had to get my case logs. I got proctored from my GYN colleagues, because GYN, they are trained to do stents. Okay, that's part of their training. And I think this is something that we need to talk about with our general surgery training. We're trained on how to do colonoscopies, we're trained on how to do laparoscopic surgery, but we just leave that stent box to the urologist, and we get into trouble. All you need to do is have one ureteral injury, and that changes your look on stents altogether. But I think having a buy-in from your urology colleagues is a good start.
Dr. Sambo, you're by yourself?
Yes.
What do you do?
Cry. I don't even have these stents in stock, so I just look around a lot and cry and try to find them and pray. But I was nodding vigorously because if I could find a urologist to proctor me, I would love to be able to place stents. And I was nodding at if we were trained as residents. I was pretty fortunate at St. Joe's because we did urology there. So, I mean, I do urology in my practice where I'm at. You know, I do certs, hydroceles, vasectomies. So I would feel very comfortable doing stents if I had the opportunity.
Go ahead.
As a Kaushik from UAB, that's a great talk and a very, topic. Some cases we see all the time, like sometimes you're on call, we see 3 of these. The question for you is, HG3 and HG4, there's a lot of data coming up about conservative management, especially like the case you showed, and even patients with focal peritonitis, pneumoperitoneum. Is there a role, in your opinion, about watching these patients, putting drains, antibiotics, and getting them through, and especially the patients with talking about immunosuppressive sick patients to avoid an emergent intervention and, risking yourself and exposing yourself to ureteral injury or other complications?
That's an excellent question. I think that summarizes the whole talk. I think the idea to take a patient to the operating room has to be individualized, first thing. And I do not operate based on free air. So just having free air alone is not my reason to operate. I look at the patient overall. I did septic shock. I remember I came around once and I had a patient that had about 6 drains, perk drains. They were put at different times, just to try to analyze it's time to do surgery, okay? I was looking for that picture so I can show you in my talk today. But sometimes you have to just decide, and the patient was young, previously healthy, but had 6 drains in an attempt to wait and wait and wait. How many drains is too much? I think acupuncture doesn't cure sepsis. So, if you have to operate, you operate.
Another follow-up question, sorry, taking your time.
Sure.
If you're in the community and you have a case of a HG3, for example, and when there's a patient in a small hospital, it's next to impossible sometimes getting into a high center or IR or whatnot. What do you think is the role of the rural surgeon doing more laparoscopic lavages and placing a drain and temporizing the situation?
I think that's a perfect case for laparoscopic lavage. If a patient is healthy, young, healthy patient that comes in with diverticulitis, and you don't have IR available, you put in 2 or 3 trocars, 5mm trocars, you lavage for about 10-20 minutes, you leave big drains right close to where you find the abscess, and get out of Dodge, and come back in about 2 months after a colonoscopy. I think that patient will be better off. We'll thank you for it, rather than trying to do a colostomy at that time.
I did that twice during COVID when I couldn't get patients transferred out. I did the laparoscopic lavage and left drains in.
And how did it do?
They did well.
Very good.
Fantastic talk. System. Do you believe in mesalamine or vaccine for uncomplicated diverticulitis? That's my first question. And then the other question is, diet in diverticulitis, both acute and preventing
Absolutely. I did not talk much about uncomplicated diverticulitis, but yes, so mesalamine and rifaximin are now considered standard of care for recurrent diverticulitis, or stage 1 or stage 2, if they fail the first-line therapy, like ciprofloxacin. So those are patients I leave that for. And yes, diet is a big component of it. So this is how patients fail management on stage 1 and stage 2. They go home on a regular diet. So I tell the patient, listen, you're going to hate me because you have to be on this liquid diet for 2 weeks with diverticulitis. It's a pressure problem. So the first thing you have to do is reduce the pressure in the colon and it will heal itself. So yeah, diet control is the key to avoiding progression from 1 and 2 to 3 and 4.
How about the patient? Do you do liquid, full liquid, when they are here?
When in the hospital, I start with clear liquids, and before they go home on full liquids and a blender.
Thanks.
Thank you.
Okay, great talk. So 2 questions. First, did you really get CEAs on these patients? And let's say CEA is high preoperatively, or you probably find a concern for cancer. Would your approach certainly be different?
Absolutely, thank you. That, by the way, is my boss. He's the chairman of my department, Dr. Nasser. All right, yeah, so absolutely. So in fact, I came up with a protocol for our department that for patients, especially if they're unfunded, okay, this is the trick now. Patients that come in with diverticulitis unfunded, guess what? They fall through the cracks, especially with stage 1 and 2. Now they come back later, 2 months later with stage 4 cancer. Okay, so you missed the initial because you manage them medically, but I think getting the CA level can help you with the treatment plan for those kind of patients. Because you know they're not going to follow up. But if the CA is very high and you can't get a colonoscopy, you have a push to put them on a short leash by doing either a colectomy while they're in the hospital and taking care of the cancer because they actually have cancer. Again, CA level is not 100%, I agree. But it's the best thing you have for somebody who will not follow up or will fall through the cracks.
Thank you very much. It was an excellent presentation, a good surgical rectal symposium today. So, just a quick question about lavage, which you're talking about. I normally have in contact being an acute care surgery, also when I take calls, I don't use water aspiration. I just aspirate the same principle like IR does it. So I do diagnostic laparoscopy and aspiration of the pus and put a couple of veins. So have you had any experience of doing the other way around rather than lavaging? Because I see when you put a water there, the chances of developing abscess more higher.
Absolutely. That's a great question. I think this is the one of those things that we talk about. Dilution is not a solution to pollution, okay? I agree. When I lavage overall, even for acute appendicitis, I'm very careful not to spread the liquid everywhere if it's a localized abscess. Now, if it's a generalized peritonitis, the cat is already out of the bag. So you want to lavage all quadrants, all 4 quadrants that are dependent, subhepatic, subperisklenic, pelvic, paracolic gutters, intraloop abscesses. You want to break all of that out and leave multiple drains, not just one drain. However, if it's a localized abscess, like a stage 2, and you couldn't get IR to place a drain, I think just doing a localized irrigation and drain it. So I apply a little bit of liquid, suck it out, put more, take it back, without spreading it all throughout the entire abdomen. I agree with you. I think there's a role for localized irrigation based on the patient.
Great talk, Kizzy. This is important for the learners, the residents and students. And if you're passionate about something, when a boring topic, you can make it exciting. And that's a great antidote for burnout as well, right? So my comment is, Medtronic do train surgeons in doing stents for a weekend course, in Vegas or someplace. So they take a couple of my colleagues to that. And one of my colleagues do, what he does is he injects ICG instead of putting the stents in ICG up into the urine, and that stays in there for a while. That can also help with some of the body stuff. And congratulations on a nice session.
We do still have a lot of time, so since this is a colorectal symposium, I think we use the opportunity to talk about a few things, i.e., some diverticular disease can be a very difficult problem to manage intraoperatively. So what I want to concentrate on now is some of the intraoperative considerations when you get in there. And some diverticulitis is very low and it's distal sigmoid and it's not, your chip shot, mid sigmoid or distal descending colon diverticulitis, especially in that acute setting when you get in there. And Dr. Kondylis, you and I remember the ones where we had to be honey badgers when I was a fellow. And I would like to start with you, and I guess I'll give you the mic. what are the tips and tricks that you have when it comes down to taking out that sigmoid colon that is almost affecting the rectum as well?
The difficult ones are literally at the top of the rectum, or where the low sigmoid perforation is folded over onto the rectum. And you have to get on rectum proper. You need to mobilize the rectum, get underneath it, and work up. And if that still doesn't give you enough height, because it's all about the height. If you can get some elevation, it's a million times easier. Then you have to mobilize sometimes the whole splenic flexure. You mobilize everything you can so that you make the hard part of the operation limited to a much shorter geography. Yeah, they're not easy, they're not pleasant. You're tired when you go home, but I mean, the real key is go to the rectum, because the rectum shouldn't be involved. It might be scarred, it might be angulated, but at some point on the rectum, you're going to have good planes that you can get into to have access to the disaster.
Absolutely. I agree to that. I think I'll just add real quick. I think the point you made about starting from known to unknown is key when dealing with complicated cases like this. So my approach robotically is different from my approach open. So my approach open is exactly like that. I start from the rectum, transect the rectum first, on the top of the rectum, with a stapler, and then walk my way backwards. I don't take the ureter, I don't take the vessels first, because then you can injure the ureter. Then I stay close to the bowel wall, if it's a diverticulitis case, to avoid injury to the ureter, and then walk my way back upwards. However, for robotic surgery, if you transect the rectum or the rectal stump first, you lose your exposure. So you need to have the rectum or the colon then held up. So I start the other way around. I restore the anatomy, which means any adhesions, I take them down from the colon. I leave the abscess for last. I start laterally, then get enough elevation, and then walk medially to take the inferior mesenteric artery. But that's my approach, my standard approach to this.
I'll even add that that's the advantage, I think, and I find with approaching these cases even more so with robotic than anything else, because of these tough cases, lower the sigmoid. I think that visually you have a little bit better chance of conserving the ureter, seeing the ureter. Your anatomy, to me, feels like it's a little bit clearer. You can really dissect and get your adhesions down a little bit easier than just the finger breaking. You have less chances of trauma or complications to the surrounding organs. So I think it's a little bit easier with the robot to get on the rectum, because your anatomy is a little bit easier and clearer to see. And when you need to mobilize the splenic flexure, you just flip the boom, and it's also a little bit easier to do that. You have a little bit more room to play. If all else fails, you've at least done some of the mobilization robotically, and you can then open to get the rest of the big bone with having cleared out some of that other stuff.
Well, I'm very difficult diverticulitis that I find robotic works, but I do that very difficult phlegmon. I do a Handes's technique sometimes. The Handes's laparoscopy I find is an excellent place in this very difficult diverticulitis, because you have the pneumoperitoneum there, then you also have the ability to tactile feel with your hands, and it just makes the case a lot easier. You also, just like Doc was talking about, if you want to get into the rectum, you can go from known to unknown. So I also find getting down into the pre-sacral space just opens a whole plethora of opportunity to get the case done. Once you can just get down the sacral promontory and get into the pre-sacral space, the case is much easier.
Yeah, I cannot emphasize that enough. Getting to the rectal space. When you do that at rectum, there's nothing erect about the rectum when it's in there, but you can actually pull it off and it becomes erect. Dr. Kidwell?
And I would agree with that, Dr. Imo. I think getting into the pre-sacral space is the key. On these really difficult ones that are adhered to the uterus, bladder, left pelvic side wall, to me it's actually easier to do an open incision, put in a Lexus wound protector, and then put in a Vogue Walter. and that kind of provides me with pretty good visualization. And I am amazed that you pretty much close your eyes and feel what you need to do. And then, so I do that and then get in the presacral space, and usually I lift things up enough to come distally or start proximally right underneath the descending sigmoid junction and stay with like a large jaw and seal or something and head down to my distal transection site.
One of the questions people want me to ask is, what leads to recurrent sigmoid diverticulitis after a resection? Recurrent sigmoid diverticulitis after a resection? Let's take that.
For me, what I like to see is evidence of inflammation. The fact that they come to the office and they say they have the exact same symptoms that they had before, there's a component of dysfunction. People feel different. Transit through the segment is not entirely normal necessarily. So I try not to chase after non-inflammatory recurrent symptoms very hard. I like to see a CAT scan with inflammation or a gastrographin that shows mucosal edema, something that tells me that there's something there that can be potentially addressed surgically. Otherwise, it's medical management for me. I always worry when the patient the original case was done at some other place, that, was it convenient to put the anastomosis a little higher than it should be? So if I scope these people and I see diverticuli below the anastomosis, I'm pretty frank with them that they may need a revision. I'm trying to be realistic about that. All right.
I mean, that's key there. I think for me, every time I've seen recurrent diverticulitis after surgeries, they just didn't get to the rectum. And I think that's why getting into that presacral space is, it's key. And like you said, there has to be evidence of real symptoms and real inflammation for me to take it back for revision. But most of the time, if you've gotten to the rectum and you've resected your sigmoid, you've mobilized what you needed to mobilize, you've gotten your proximal point of transection was soft, pliable rectum, pliable colon, like we were talking residency, you shouldn't have recurrence that often. Usually, if there was recurrence, one of those steps was missed.
Yeah, I mean, I would agree. I agree. I think before you do anything, you scope these patients and check where the anastomosis is, and check if there's any diverticulum below the anastomosis. I think there's another concept that can happen, and we notice that in the OR sometimes, is we take these patients for diverticulitis or any other surgery, and you are actually at the top of the rectum, but when you put your EA in, it just doesn't get there. And so there's this functional problem just before there where there's a narrowing. And diverticulitis is all about pressure, right? So if you have those instances, instead of trying to force a smaller stapler, take your time to come below that area of functional bending. Sometimes just mobilizing that plane frees the rectum up so that there's no real functional narrowing. And I think that reduces your risk of recurrent diverticulitis down, because you really are on the rectum, but just before that area is just a little narrow functionally, maybe just at the rectovaginal area, just at the anterior reflection or something. It's just not giving up. And I think make sure that your EA goes all the way, it's free, and you're above, you're at the level of the upper normal rectum, and I think the chances will be less.
Yeah, the question is, what's usually the problem that creates a recurrent diverticulitis? And I think you answered it. I think it's you don't go low down enough on the rectum, and I think it's you don't go proximal enough to get supple tissue. So if you do those things, your recurrence rate should be 5% or less.
Yeah, so avoid a colosigmoid anastomosis, right? Avoid a colosigmoid anastomosis. You want to make sure you take out the distal sigmoid to the rectum.
Robert, two questions. One is, the technique to avoid colovaginal anastomosis. and the other one is, what is the EA size that is acceptable? Lowest size. EA size? Yeah.
I can take those two questions. So you know, I have been there, done that. Okay, personally, I have created a colovaginal anastomosis as I think I was a fourth-year resident. You know, and unfortunately, it was found out. Fortunately, it was found out right after it was created, and it can happen very easily. So after that incident, I came up with a pathway to completely avoid it altogether. And for my procedures, I have someone who is helping me staple that is usually an FA or maybe a pre-FA, not even a resident stapling the anastomosis. So this is what I do. I take the medium-sized EA sizer and put in a vaginal vault. That's the first step, to ensure that nothing else goes there. The second step is to make sure you have good lighting. So the person doing the staple has to have good lighting. Then with the other EA sizers, the smallest one I use to dilate the rectum to ensure that there's no cuff or a fold on the sigmoid colon. And pass it with the biggest size EA sizer. When that is done, I ensure that they leave a finger in there before they put in the stapler in the right hole. It's so easy to mess it up because I did it, so I know how easy it is. And when that is done, I make sure that the vaginal septum is separate from the rectal septum, because sometimes you may have a partial anastomosis to it catches at the back lip of the vaginal wall, especially after a hysterectomy. So I have the EA size in the vaginal vault lifted up during the anastomosis. So those are the steps. What do you do?
Yeah, so the risk factors is obviously prior history of hysterectomy, because you know when the uterus is there, the chances are very small that you will do that. But what I do usually is I always make sure I have one finger inside the vagina while I put the EA staple, right? Because you know, so you know where the vagina is, then you put the EA staple, right? And then that's what I tell my residents all the time. When I was a resident, there was also an attendant who this happened to. Thankfully, it wasn't with me, but that's a nightmare, you know. And the other part that everybody want to avoid is making sure you don't catch the posterior vaginal wall. If you don't mobilize and separate the rectum and the vagina enough, if you don't do that, it can catch the posterior wall. So that is how people catch it and not even see it until post-op, right? So. One more question. I think we have 5-7 minutes left. We're on the roll.
You're asking the EA question.
Yes, EA question. So how do you, what size is too big, what size is too small?
I standardly use 29 EA. That's all I use all the time. And the key is, you know, obviously you got to know how to dilate the colon plot to be able to put the embryo in. If the colon is too thin, I can give glucagon to dilate the colon a little bit. I use my finger when I do this. I mean, I don't know if you know this, a lot of colorectal surgeons talk about their fingers all the time. So I know this size, if I can dilate the proximal bone with my thumb, it will fit an 29 EA ankle. So usually that works. So 29 is what I use. I think you use 33, Dr. Kondylis at some point, right?
The longer I practice, the smaller I go. Look. Sort of, I know from stenting that if they have a 16 or 17 millimeter lumen, it's asymptomatic. So anything more than that is fine. So I've gone more to a 25. It passes easier. It's actually pretty uncommon.
Yeah, I mean, so long as they have good, all the tenants, like good vascularity, non-intention, and they're just laying in. So strictly is very small, but I use 29. What do you use up there?
I use a 28 or 29. One of the hospitals I work at has 28s, not 29s. That one has 29s, not 28s. I will say some of my predecessors would always teach me that bigger is better, and that there's no reason to go smaller if you can go bigger. But I have, my experience is that that's Texas. But my experience is I like not struggling and destroying the tip that I cut into the colon that I'm trying to get the handle in. So those sizes are pretty universal.
So one more question, guys. This one is critical because most of the reversals we do, like for sigmoid diverticulitis, Hartman's procedure, most of the reversals we do come from somebody else, right? when I do my own Hartman's, I set it up for the reversal myself. I make sure that when I come back, especially the open cases, when I come back, it's not going to be a 6-hour surgery, right? A lot of scar tissues and whatnot. So what do you do to prepare that come back? So when you're coming back, it's an easy surgery and reconnection. Starting with you again, Doctor.
Now, my descending limb, I'm mobilized enough to be happy with the stoma and not more. I try and save the splenic flexure because I know I'll need it. And I'm very judicious about wrapping the whole stoma limb in Seprafilm, and I coat the entire pelvis in Seprafilm so that the less time I spend taking down inflammatory adhesions, the better. And I don't rush the paper back. I like to see them fully functional before I close this.
How many months?
3 months. I mean, people want to be closed in a month, and people show you literature about, there's a guy out wherever, he's closing people in 30 days or 14 days.
He's a liar.
Yeah, I'm not that crazy.
Yeah, you want to hurt yourself, yes.
So I do pretty much the same thing. I try to avoid taking down the splenic flexure, separa, and I tag my rectal stoma. I always tag it with my proline. It's my suture that I know when I come back, and I think also it helps avoid sort of that sunken hole that the rectum sometimes goes to, which is pretty tragic. I tell them 6 months, take it or leave it. I don't do 3 months. I will cry with them, but 6 months is my minimum.
Yeah, there's something similar. When I'm doing Hartman's, for instance, I don't, as much as possible, mobilize the splenic flexure unless I leave part of it just to get the ostomy up. And once I do that, I leave the rest for the reversal. If the diverticulitis is a bit like around the mid-sigmoid, I actually leave a little stump of the distal sigmoid. So when I come back, I resect that, and then that way I'm just on a normal upper rectum, it doesn't sink down. That's another thing I do. And if I've had to, for instance, very distal sigmoid, I've had to mobilize and I get the normal tissue of rectum, and I'm comfortable with it, I would anastomose and just give a loop ileostomy, and I feel the patients do well. But that's the set of tricks I do. Then if I do it open, I always put a stitch. If I don't do it open, I just do it.
Similar, I wait 6 months, and that's kind of a hard rule. I find that the adhesions are less bothersome then. Also, I always tag the stump of proline as well. I tag both corners. I find it helps me know knowing where the two corners are helps me get posteriorly easier. And yeah, again, if you can get away with not doing the splenic flexure mobilization, you still have good reach to create your ostomy, I'll do that.
So for me, it's kind of a hybrid. Instead of just tacking the corners of proline, I actually run a suture across it to avoid a rectal stump leak, which can happen, which is very rare if you go down to the rectum enough, but it can happen. So I run the 2O proline from one end to the other end and leave 2 tails so I can find it in the future. I avoid taking on the splenic flexure. I think if you take on the splenic flexure, you have more adhesions that form in that location. To avoid an ostomy retraction, what I try to do is, initially from the rectum, I stay close to the rectum, but as I go down to the sigmoid, I dive down towards the pedicle. That way you can leave a good mesentery with enough blood flow. I think that's the key.
So to summarize, I think this is key. I really wanted to talk about this. One is, Seprafilm, adhesion barrier, right? You want to reduce the amount of adhesions, and I cannot stress that enough. I did one case with a fellow, and he was like, "You did this open?" I was like, "Yeah." "What did you do?" I was like, "Let's go and review the inventory of the index operation and see whether or not I use Seprafilm or not." And lo and behold, Dr. Kondylis, this is how he trained me. I put a bunch of Seprafilm in there. I think 2 or 3 packets, put it all over in there, wrap it around the ostomy, put it in the pelvis. Because the last thing you want is to get in there and find that the rectum is disappeared. And that's exactly, I get a lot of those people both the case and wrong and say, hey, I can't find the rectum because it has reperitonealized. And so you want to put those separate fluid in there. I love the sutures. I do the sutures all the time. Sometimes I do leave the sigmoid stump on, just knowing that that will allow me to be able to see the sigmoid the stump later, because if you leave it long enough, you just like, you got to come back and know that you have to remove that sigmoid stump and make sure you document that. And the other thing that we didn't mention is what do you do to set up the successful reanastomosis? You want to do a preoperative proctosigmoidoscopy to look at that stump, make sure that that stump is actually healthy, and also to kind of know how much work you have to put in during the operation. You want to do sometimes do a CT rectal contrast is what I usually do all the time to kind of see what I got. Sometimes it's always good. The more information, the more data you have before you walk into the operating room, the better. And I think that concludes it. We're on time, right? We're good. All right. Very good.
Can I put a slide for your webinar, that ICS webinar? There's a great webinar that these guys put together on colorectal disease. I would urge you to go watch it. It's on YouTube. I don't know where. Please go back. It's one of the better webinars you've ever seen.